So the first question I have for you is, what are the positive changes with regard to cancer care have you observed as a result of the pandemic?
So I think there's been more virtual management of cases. I
Mm-hmm.
think we've been able to, it's caused all of us to focus on building a more robust and
Mm-hmm.
a more sophisticated telecommunications network.
Mm-hmm.
So more virtual meetings, more ward rounds. Let me find, I had a few things I had written down. And also learning how to spend time out of the office,
Mm-hmm.
and maybe a slowdown of all this work that we've been doing at breakneck speed.
Mm-hmm.
It has forced us to slow down and reflect, and to be uh, to make sure that the time we spend is more qualitative
Mm.
instead of quantitative, to
Right.
really take time to make sure when you do interact with your colleagues and with your patients that you really get to the meat of the matter. And
Mm-hmm.
so more efficient, I would say, that in
Mm-hmm.
terms of any human interaction is caused us to be more efficient, because you're usually limited by the amount of time you can spend in any kind of virtual contact. So
Mm-hmm.
those are the positive things, I think.
Yeah. Okay, that's great. The second question I have is, do you think the changes should be maintained after the pandemic?
Well, Dorothy, let me go back. I want to add something to that too.
No problem. Go ahead and
So,
add. Mm-hmm.
okay, so I want to talk about it just from a research perspective, in terms of cancer research.
Mm-hmm.
So I think another benefit or positive is that it has caused us to be more innovative. For instance,
Mm-hmm.
we have several cervical cancer screening and we recruit those screening population. Well,
Mm-hmm.
COVID decreased the number of women who were coming in for screening.
Mm-hmm.
And so we had to figure out a way to, and so we, it caused us to, I'm sort of trying to go back to my sheet that I have
Yeah.
here. It
No.
caused us to find new partners, such as traditional healers,
Right.
because they have a patient population, and we had
Mm-hmm.
never accessed that patient population.
Mm-hmm.
Partners to that are sometimes overlooked in research, commercial sex workers
Mm-hmm.
that we paid some special attention to.
Mm-hmm.
So this allowed us to, who needed the services the most, or those who were overlooked, and to establish some of these new partnerships, again, with traditional healers, individuals in the private sector, et cetera, et cetera. And I think those are things that we can build on in the future once the COVID pandemic is over.
Okay. Okay.
Okay,
Any other changes that you may want to talk
go
about?
ahead. Um, no, not those that are positive. I can tell you about some that I think are negative,
Yeah. Sure thing.
if
Please
if
do.
that's your next question. Yeah. So I think the negative effects is, the lack of person-to-person contact. I
Mm-hmm.
mean, telecommunication is nice, but
Mm-hmm.
there's always something. I mean, we're social beings,
Mm-hmm.
and we weren't created. I don't think God created us with all this technology in mind. So
Mm-hmm.
Um, and I think there's something that we miss from seeing and touching and feeling and being close to another human being.
Mm-hmm.
I think we miss that. There's certain nuances in body movements and
Mm-hmm.
reflections and eye movements
Mm-hmm.
and you know all those things that you don't that you know we talk more than through our voice, and so
Exactly.
so I think we miss some of that.
Mm-hmm.
Um, and then there's lack of safety in the workplace. You know, you always want to feel comfortable coming to work.
Mm-hmm.
And when you're frightened and you got on mask and it's just, you
Mm-hmm.
know, it just doesn't feel the same. So I think that impacts us and how close to people we get, how quick we want to get in and get out. So it's just this whole big thing of safety. And then, you know, us and our colleagues, you know, can get infected with this. I have people in my group that I work closely with who've been exposed, and
Yeah.
one or two people have the infection.
Yeah.
Uh, one of the big problems
Mm-hmm.
is delays in patient therapy. We've
Mm-hmm.
had to change. I mean, I'm a cancer surgeon, so we've had to,
Mm-hmm.
you know, change the way in which we
Mm-hmm.
prioritize patients for cancer to those who are severely symptomatic. So
Mm-hmm.
some of the patients who would benefit from early intervention, so like those with maybe early stage ovarian cancer,
Mm-hmm.
early stage cancer who are not bleeding,
Mm-hmm.
small lesions on the vulva, early stage cervical
Mm-hmm.
cancers, things that we really go after aggressively.
Mm-hmm.
We're now sort of putting these patients and patients who also have pre-malignant disease,
Mm-hmm.
we're sort of putting them on the back. We can really go after these patients because cure rates a high probability of symptomatic and
Exactly.
emergency cases of these
Yeah.
patients who have early stage disease. That disease is going to progress, and then some patients we're going to lose. You know, they're just not going to come back, or they'll come back, and
Mm-hmm.
you know, there's not very much we can do but
Mm-hmm.
palliation. So I think those are some of the negative things about it.
Yeah. Yeah. Um, so you had mentioned some of the positive changes. Do you think we should maintain those positive changes after the pandemic?
I think so, Dorothy. I think we should really make an effort to
Mm,
use this technology that maybe it would have taken us
much longer.
more time to embrace, you know. And just for instance, you know, we one of the that's okay. One of the issues we have in cervical cancer
Mm-hmm.
is monitoring and evaluating or quality assurance of some of the things that the providers do. And
Yes.
it's been difficult to do that as the services has been scaled across the country, because the people you want to do the quality assurance are really your experts, right? And
Yes.
so they would have to travel long
Mm,
distances, and
yeah.
then they would be out of pocket and couldn't do their regular jobs.
Yeah.
So I think we're looking at now using some of the telemedicine and
Right.
virtual kinds of communication
Mm-hmm.
to do quality
Quality assurance.
assurance. And so I think forward faster than it would have occurred had
Mm-hmm.
we not embraced this technology. And I think there's less resistance to it now from funders and from government. You know, you're somebody, oh, well, let's do telemedicine. Nah, and telemedicine now is just everybody's doing it. Everybody's on Zoom. Everybody's. So I think it's now part of the vocabulary.
Yeah. Exactly.
It'll be easy to do. So, and I think when new things come like artificial intelligence for cancer diagnosis
Mm-hmm.
or telepathology, I think it'll the acceptance rate will be very high. And I think yes, we need to really accelerate, particularly in Africa, and incorporate this a great opportunity to now move Africa forward in terms of building this kind of telecommunications infrastructure. So
Yeah.
I think we should embrace it wholeheartedly.
Great. Thanks for that.
It's 19 hours.
Um, what do you think the barriers to maintain? You've mentioned attitudes of government or funders. What other barriers
Yeah,
do you think are there to maintain the changes?
I think cost. I think cost and just trying to figure out how to make it happen. Our internet system is
Mm,
probably not as
mm,
robust as it
mm,
needs to be.
mm,
It's not as fast as it used
mhm,
to be. You can't get as picture. Just the basic infrastructure is
mhm,
going to have to rapidly improve in order to carry the weight of all this new technology. And then I think that we're going to have to patient confidentiality and things that will allow people to be identified, in a public kind of
exactly.
manner using this kind of stuff. So we're
Exactly.
going to have to safeguard, uh,
Mm,
uh, yeah, patient identification. So
mm,
all that's going to come in later.
mhm.
But so I think those are the two basic things: cost,
Cost.
the 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 sophistication of the basic infrastructure, and
Mm,
then the whole legal issues around ethics around patient
mhm.
confidentiality.
Yeah, those are good ones, Prof. Thank you. Is there anything else that you would like to say or to ask about the study or anything?
No, no, I'm okay. But I'd like to ask you what you think about I'd like to ask you for your opinion about some of those same things that you just asked me. Would you be able to respond what you think of the positives, the negatives, the
Yeah,
barriers, and sort of where we need to go from here in
100%.
cancer care?
Yeah. The positives, I think for us, we have seen a lot of shift. The first thing to say, a lot of stuff that we've been wanting to do that we didn't do. Other than the telemedicine, for me, I think that's really a positive thing. Moving on to a virtual platform. And I feel we do have solutions, even in places like Zambia, where you've got rural areas that don't have access. You still have infrastructure like at district hospitals or, at places where you could have a central place for a person to actually access that rather than travel the whole 12,000 kilometers to the central place. I was actually in a bank the other day, and I noticed that the banks have, booths where you can, if you don't have internet at home, you can actually access internet in those booths. So in a similar way, medicine can do that. You could have these peripheral centers, with these booths where villagers could come and access this type of help without traveling long distances. So telemedicine is definitely something that we should move to. And I'm also excited about telepathology. I think that's the processing room should actually move more to the clinic area, and we're actually just sending these
Mm,
prepared slides out to the pathologist. So that is definitely a positive. The other big thing I think the COVID pandemic has taught us is value. We have learned how to survive with the bare minimum, and we have learned
mm,
how to, say what is really valuable for this patient, which I think cancer is really a culprit. Our field is a culprit of, going for the tiniest bit of benefit, because it's such a scary disease and people will throw whatever they can for that extra 1 month. And even if we know that that 1 month isn't really valuable, we've forcibly done it. Even if we know that what that extra fraction of radiotherapy doesn't really add it, we've taken so long to change from 20 gray in 5 fractions to 8 gray single, which numerous studies told us before that they were equally effective. So the fact that we have now created a value-based system, I think we should maintain it. We should not go back to giving patients unnecessary treatment, everything.
mm.
For the first time, I've seen Zambians say, we're not going to give chemo because, I was always
Wow.
trained to say, when you've got an ECOG status of 3, you don't give that patient chemo. But when in Zambia, we say it's a cultural thing. But because of the pandemic, we can't keep patients, people have come to accept that, no, this patient actually will be better off on pain control, symptom management, and we don't need to give this patient anti-cancer drugs that we know are just going to reduce their quality of life. So that for me, the value-based, and I could go on with thousands of examples, but just to kind of like have that, clear for you, it's that value-based oncology care has really come out during the pandemic. Then the other thing that is also very basic, but something that, we're lacking is the hygiene practices, for the simple cleaning of the institution and ensuring that, twice or three times a day and everything is clean. That had really taken a dip. But with the COVID pandemic, accounts all of a sudden do understand the value of disinfectant because they are equally affected. So as a side effect, we have benefited. And it's really, it's something that is so basic, but it's something that is highly lacking in our institutions, and something that doesn't require too many resources. So I do hope that the cleanliness and everything will be taken into account. Then lastly, for me, what also came out was the mental health of workers. Already healthcare professionals in low-income countries suffer from a lot of moral distress because you know what you're supposed to do for the patient, but you don't have the resources. And for a long time, nobody really listens to this distress. But the COVID pandemic shut people down and really made the management or the leadership of the hospital to actually pay attention to the mental health of workers, which makes a massive difference because mentally healthy workers are compassionate, they're patient, and that's what a lot of our patients need, because most of them come in locally advanced cases, and there's really nothing much you can do. So having a workforce that feels valued and is taken care of mental health wise is something that we need to keep up, and we need to continue having access to these psychological services and so on. Now, what would I consider a barrier? I think I echo your opinion in that it's costs. Everything has a cost. And then secondly, I would say attitudes. We often overlook this. It's really attitudes, because after some time, we saw it when the first wave was going down. People kind of relaxed. Now the second wave has hit us bad, and prominent people are actually dying and all that. Again, we've lifted up our guard. So we have already seen that attitudes can dismantle systems that have been well built and you think are robust and sensible. So attitudes is something that is one of the greatest barriers for me. Yeah, that's it, Prof.